Welcome back. Today we take on one of the harder intraoperative decisions in gastric surgery. The tumor that is stuck to an adjacent organ. Do we resect that organ? Which organ changes the calculus? And does it actually help the patient live longer? We will work through the evidence for multivisceral resection in T4b gastric cancer. First, definitions. In the AJCC 8th edition, T4b is a tumor that directly invades an adjacent organ or structure, and it is distinct from a T4a, which is penetration of the serosa alone. The organs involved in order of frequency are the pancreas, the transverse colon and its mesocolon, the spleen, the liver and the diaphragm. Each of these behave differently, and that difference is the theme of this episode. Two facts frame everything that follows. First, adherence is not invasion. Neither the CT scan nor the surgeon's finger can reliably tell a genuine malignant infiltration from a dense inflammatory adhesion. In fact, only about 45 to 65% of clinically suspected T4b lesions turn out to be truly invaded on final histology. Second, the moment you divide that adhesion, you breach the plane and seed tumor, converting a curable operation into an incurable one. So the rule is treat the suspicion as invasion and resect en-bloc. Start with staging. Contrast enhanced CT is the workhorse, but its accuracy for adjacent organ invasion is only about 60 to 85%, and it characteristically overcalls invasion. A lost fat plane next to a pancreas or mesocolon is sensitive but not specific, and inflammation looks exactly like tumor. Endoscopic ultrasound refines T-stage for proximal and junctional tumors, but no image settles the adhesion versus invasion question before pathology. Because occult peritoneal disease is common in these locally advanced tumors, staging laparoscopy with peritoneal cytology is mandatory before you commit to a major multivisceral resection. Positive cytology, CY1, is M1 disease, and it takes the patient off the upfront surgery pathway. There is no sense removing a pancreas and a colon in someone whose peritoneum is already seeded. So here is the central surgical principle, and every guideline agrees on it. Where the tumor is adherent, you remove the involved organ en-bloc with the specimen to obtain an RO resection, and you never divide the adhesion. Peeling the organ off sharply or bluntly converts a potential R0 into an R1 or R2 and spreads the tumor along the dissected plane, en-bloc or not at all. So how often is our suspicion right? Take a clean example. 40 patients with gastric cancer adherent to the transverse colon, all resected en-bloc to R0. On pathology, 55% were truly invaded and 45% were inflammatory adhesions only. Across series, the true invasion rate runs from a half to 2/3, and it is organ dependent. Higher for the mesocolon and spleen, lower for the pancreas, where peritumoral pancreatitis is a great mimic. And the distinction is not academic, it drives outcome. In the same cohort, 3-year overall survival was 26% for a truly invaded T4b patient against 78% for those whose adhesion was benign. Read that carefully. Much of the apparent success of aggressive surgery actually accrues to the patient who never had true invasion in the first place. It is a lesson in how selection flatters a series. This brings us to a central question. Should we subclassify T4b by the organ resected? The evidence says yes, because the organ determines two things at once: the morbidity you add and the biology it signals. Splenic, colonic and diaphragmatic resections add little, whereas pancreatic resection, above all a pancreatic or duodenectomy, is the adverse outlier on both counts. Several authors now argue that the specific organ and the number of organs deserve to be the formal prognostic descriptors. Take the organs one at a time and start with the spleen, because here we have a randomized answer. JCOG 0110 enrolled 505 patients undergoing total gastrectomy for proximal cancer, not reaching the greater curvature, and randomized them to splenectomy or spleen preservation. 5-year survival was 75% with preservation versus 76 with splenectomy, non-inferior, while splenectomy increased operative morbidity and pancreatic fistula. The conclusion is settled: preserve the spleen unless the tumor directly invades the greater curvature or the splenic hilum. At the low cost end are the transverse colon and mesocolon, the diaphragm, and direct contiguous liver invasion. Not hematogenic metastasis, but the tumor growing straight into the left lobe. These add little morbidity, and R0 is readily achievable, near 100% in selected colon series. For these organs, if they are adherent, resect en-bloc without hesitation. The distal pancreas sits in the middle. A distal pancreatectomy, usually with the spleen, pays a fistula tax, that is the clinically relevant pancreatic fistula, in roughly 20 to 30%, and that is the complication that drives the whole recovery. Survival is intermediate, so resect the distal pancreas only when it is genuinely invaded, and never prophylactically to chase a node. The morbidity is real and the oncological return is not. And then the pancreatic head, which requires pancreatic or duodenectomy, the adverse outlier on every axis. Morbidity is 40 to 50%, mortality can reach 10%, and worse, pancreatic head invasion marks adverse biology. Survival is poor even after an R0 resection. So a Whipple for gastric cancer is justified only in a fit patient in whom R0 is genuinely achievable and who has responded to systemic therapy in a high volume unit. It is the exception, not the rule. Put the morbidity together. Across the literature, postoperative morbidity ranges from about 12 to 60% and mortality from 0 to 14. An enormous spread because the case mix varies. What drives it is pancreatic resection and the number of organs removed. A series limited to spleen, colon or diaphragm sits near 12% morbidity with near zero mortality. Add a pancreatic head and you are at the other end. Consent should reflect which operation you are actually proposing. Does it work? When you achieve R0, multivisceral resection delivers a 5-year survival of roughly 24 to 38%, worthwhile in a disease that would otherwise be incurable. But an R1 or R2 multivisceral resection offers little over non-resective therapy. That is the whole point. The operation exists to convert locally advanced disease into an R0 specimen. If you cannot foresee an R0, the morbid surgery is not indicated. So who benefits? 5 predictors recur across every series. 1. an R0 resection, the single most important surgical determinant. 2. No negative disease, PN positive, and then especially N2 to N3 markedly worsens survival. 3. True T4b versus benign adhesion, which we saw halves survival. 4. Single organ versus multi-organ, and specifically pancreatic involvement, which flags adverse biology. And 5. Response to neoadjuvant therapy, which is where systemic treatment earns its place. Which brings us to neoadjuvant therapy. For any locally advanced tumor, clinical T3 to T4 or node positive, perioperative or neoadjuvant chemotherapy is now standard, and it is especially logical in suspected T4b. It does three things. It downstages the primary, it improves the R0 rate, and just as importantly, it tests the biology, so that a morbid multivisceral operation is offered only to patients whose disease has not already declared itself systemic. The pivotal trial is FLOT4, perioperative FLOT, docetaxel, oxaliplatin, 5-fluorouracil and leucovorin versus the older ECF or ECX in resectable gastric and junctional cancer. Median overall survival was 50 versus 35 months, a hazard ratio of 0.77. The R0 rate was higher, about 85 versus 78%, and pathological downstaging was greater. In the fit patient, FLOT is the preferred perioperative regimen. 2 Asian randomized trials reinforce this. Resolve trial from China in clinical T4a node positive to T4b disease showed perioperative S1 and oxaliplatin improved 3-year disease-free survival. And PRODIGY from Korea showed that neoadjuvant docetaxel, oxaliplatin and S1 improved 3-year progression-free survival. Different drugs, same message. Preoperative therapy belongs in locally advanced gastric cancer. In practice then, give the perioperative regimen and then restage, a repeat CT and often a second look laparoscopy to exclude interval metastatic progression. Proceed to en-bloc R0 multivisceral resection in responders and stable disease, and complete the postoperative chemotherapy. One caution, neoadjuvant therapy does not license peeling an organ off. Even after an excellent response, the en-bloc principle still holds. You cannot trust that the plane is clear. A brief word on what not to add. Bursectomy, that is the stripping of the lesser sac peritoneum, was tested in the randomized JCOG 1001 trial and showed no survival benefit even for a T4a and posterior wall tumors. So do not add it. The theme repeats, resect adjacent organs for genuine invasion, not prophylactically. Let me put the whole pathway on the screen. Suspected T4b, stage fully including laparoscopy and cytology. If M1 or CY1, this is systemic disease. If resectable to R0 and the patient is fit, give perioperative chemotherapy, restage, then perform an en-bloc R0 multivisceral resection, preserving the spleen unless the greater curvature is invaded, resecting colon, diaphragm and pancreas by the rules we have discussed, and reserving the Whipple for the fit responder. Complete adjuvant therapy and let pathology tell you whether it was true T4b or benign adhesions. Now the honest caveats. Almost all survival data are retrospective and selection biased. Fitter patients achievable R0, and there will be never a randomized trial of resection versus no resection where R0 is possible. The subclassification we have argued for is not yet codified in AJCC. Splenectomy is a settled negative. The Whipple is highly selective, and the adhesion versus invasion problem remains unsolved before pathology, which is why a fraction of organ resections will always prove in hindsight unnecessary. Say so in the consent. The bottom line then, treat the suspicion as invasion and resect en-bloc, never peel. Stage with laparoscopy and cytology. Give float for locally advanced disease. Preserve the spleen unless the greater curvature is invaded. Reserve the Whipple for fit responders and in whom R0 is achievable. The goal always is R0, and remember that the third to a half of what looks like T4b is benign adhesion, and those patients do well. That is multivisceral resection in gastric cancer from literature to bedside. I am Dr. Gautam Krishnamurthy. Thank you for watching.